Welcome to Healthcare Algorhythm. I'm Dr. Will Strimel. If you want the real story behind today's healthcare challenges and the strategies and technologies people are actually using to solve them, you're in the right place. Short conversations, clear insights, practical takeaways. Let's get into it.
And welcome back, everybody. It's Dr. Will Strimel in the Healthcare Algorithm today with Dr. Jay Harness. Jay's a breast surgical oncologist with more than 5 decades of experience and a former president of the American Society of Breast Surgeons. Over his career, he has helped shape multidisciplinary cancer care, and more recently, he's been a leading advocate for integrating exercise as a core part of oncology treatment. Dr. Harness, thanks so much for joining me.
Hey, well, good to be here, and please call me Jay. It's a delight to be with you.
Will do, Jay. Well, thank you very much. And, this is a show that's generally about the intersection of care delivery, healthcare operations, and technology. And within all that, innovation. And when people hear that word, innovation, especially in cancer care, they usually think about new drugs or new technologies, things of that nature. But you've been advocating for something much more fundamental, and that is exercise. So, how did you come to see exercise as such an important part of cancer treatment?
Yeah, about 7 years ago, I sort of stumbled into this world of exercise oncology. That's the actual name of the discipline. And as you just mentioned, I've been involved in the world of breast cancer for about 35 years, and I was really shocked that I didn't know about the science behind all this. Clinical trials started in the late 80s, early 90s, and up through last year, we have now been a little over 3,000 clinical trials, resulting in between 25 to 30,000 publications on the importance of exercise for cancer patients right at the time of their diagnosis or prehabilitation, if you will, during active treatment, and particularly in the long-term survivorship. I kept thinking, I said, wait a minute, I'm a known international surgical oncologist. What in the world is going on here? Why do I know about all this? Well, the answer is actually straightforward. All this phenomenal research has been done by outstanding PhD researchers in the fields of exercise physiology, which you're familiar with, kinesiology, even sports medicine. As a matter of fact, one of the global leaders is the American College of Sports Medicine in leading the charge for this kind of research.
Wow.
And when I started my website, Cancer Fitness, about a year and a half ago, my mission was to try and educate my own colleagues, my medical oncology colleagues, radiation oncology, surgical oncology, nurse practitioners, and others about all this incredible science, because for over 30 years, they had been talking to each other. The results of all this research have been published in their literature. Maybe there was some in your literature as a cardiologist, but then very little crossing over into the general medical literature, let alone the oncology literature.
And why do you think that was?
I don't know. I guess PhDs like talking to themselves. Maybe we wouldn't believe them. When I first got involved in all this, people said, oh, that's woo-woo, Jay. Oh, come on. I mean, everybody knows exercise is good for you, but what you're talking about, that's got to be woo-woo. No, it's not woo-woo. And second, then everyone said, oh, well, you want people to train for the Ironman contest. I said, no, we're talking about moderate intensity exercise. What is that? That means walking briskly for 30 minutes, 5 days a week. And that's where you get the 150 minutes that are nationally and globally recommended. Couple that with 2, hopefully even 3 days of resistance training. Can be done with resistance bands, or working out with weights, or going to the gym, or whatever. And there are all sorts of different forms of exercise that can hopefully get your heart rate up, typically into the low 100s, so that you really have a meaningful effect of the moderate intensity.
And then at a high level, Jay, what is the science behind it? What is the impact that exercise has?
Yeah, you just nailed it, Will. That's a big question. In other words, part of your question is what's the dose of exercise, isn't it? But, if somebody needs chemotherapy, we say, well, we're just going to give you some chemotherapy. Oh, you would figure it out, obviously, based on the patient's weight and height and a variety of things. So that's the big debate right now is what's the dose?
Okay.
A lot of research has been done, particularly at Memorial Sloan Kettering with Lee Jones on this very subject. Are the high intensity, the HIT
Hmm.
exercises
Sure.
better that you know about as a cardiologist than this moderate intensity? And it appears that it's sort of a bell-shaped curve where you sort of reach a peak. In some instances, it may be a little bit better and higher, but pretty much for now, at least, everybody's settling on the 150 minutes a week of moderate intensity. And my further response to that question is more to be revealed.
Okay. And in that regard, what is the outcome? Because of course, in cancer, like in cardiology, we're looking at big outcomes. In your case, 5-year survival, 10-year survival. Is that this when you're studying the impact of exercise, is it making an impact on those big endpoints, or is it more around sort of quality of life type measurements?
All of the above. There's been a lot of data with all these publications on patients being able to say during chemotherapy that they're exercising in between the doses of chemotherapy, that they're better able to tolerate the recommended dose level. They recover more rapidly from the dose of chemotherapy. People feel like crap for a few days, but the
Yeah.
idea is so we both gonna feel that way. Once you get over that acute effect, if you will, get your tush off the sofa and let's get moving,
Well, that
okay?
was gonna be one of my big questions is that, it is difficult and to tolerate, and so how do you find patients willing to engage? I mean, I imagine you have to really do a lot of kind of work up front to get them to sort of believe in the concept of it.
Yeah, that's really true. So again, getting back to my website, cancerfitness.org, part of what people have asked me, GJ, what's your target audience for the website? The
Uh-huh.
answer is two targets, maybe even a few more. But number one was my own colleagues, and second of all, our patients, and thirdly are their family members who are going
Sure.
to encourage them to get moving. We can walk in and say, Susie, I know you feel like crap. Let's get over that. Come on, let's get moving. And one of the best ways is obviously to exercise with a partner, a spouse, a friend, have an appointment. We know there's a much better compliance when people do that. Anyway, so not only are we going to help people get through the acute effects of their treatments, but we're also going to help them improve their quality of life for sure. There's a lot of data about improving the quality of life. What's fascinating, part of the studies going on right now, Will, is aerobic better than resistance training? And we know that aerobic, you would, as a cardiologist, know that aerobic is obviously really good for the heart and lungs.
Mhm.
What it ends up when it comes to quality of life, when comes to maintaining body composition, which is
Mhm.
really important, that resistance training is actually the more important of the two forms of exercise.
Absolutely, right. I mean, I have found, and I tell people all the time that the older we get, the more important resistance type exercise is, actually.
Yeah, no, it's absolutely true. And as we age, we're losing muscle mass naturally. Well, the average age of a cancer patient is very late 50s, more typically in their 60s. So they've already lost some muscle mass to begin with. And then to have that be accelerated by treatment, it just makes the situation worse. And then, as far as recurrence of cancers and improved long term survival, the absolute gold standard bombshell report came out last year at the ASCO meeting, the American Society of Clinical Oncology meeting, the largest meeting in the world of medical oncologists. It was called the Challenge Clinical Trial.
Okay.
This was from actually Australia and Canada primarily. By the way, the Aussies are the world leaders in this whole area. It's really cool. So are the Western Canadians. But this took 20 years to do this trial from the absolute inception to the report at ASCO. Involved almost 500 patients in each group, the control group and the exercise group. Couple keys here. One is that the exercise group was structured exercise,
Hmm.
not was handing somebody a pamphlet and saying, go do the following things. The first year of the 3 years was done on site at the medical center,
Okay.
and the next 2 years could be done off site, but closely monitored. The follow-up was almost 7.9 years, almost 8 years.
Okay.
There was an improved survival in the exercise group of 37% and a lower recurrence rate in the exercise group of 28%.
A lower recurrence rate.
Yeah,
That's even
and
more
that's a recurrence of either the original cancer or a different cancer or dying from an all cause, such as cardiovascular disease.
so that's a really important point to highlight from my perspective, because you could understand if you took a group of people and put them in a structured exercise program, why you might start to see benefits just from that. But to get to a point where you can demonstrate a decrease in the recurrence of cancer, that's fascinating.
Yeah, I happened to live stream the session. This was a plenary session at the ASCO meeting. I'm going to guess there were 9 or 10,000 people in the audience. At the conclusion of that presentation, there was a standing ovation for
That's wonderful.
4 minutes. That same day, it was published online in the New England Journal, and the editorial in the New England Journal said, "Okay, oncology, time to get going."
I mean, think about it. An intervention, if it were a drug that improved 5-year or 10-year survival by 37%, everyone would be paying for it, right? That's
Well,
amazing.
not only that, but actually, when you look at just statistically at the impact of adjuvant chemotherapy, at
Right.
best, adjuvant chemotherapy might have a 32% improvement. But for this thing to be 37%, and for the study to have been so solid, I mean, rock solid, it's really shifted the momentum. There's been an interest in exercise oncology slowly building. But I think this thing has finally set it off. And then the next question I can anticipate you're going to ask me is, wait a minute, Jay, why isn't this standard of adjunctive
Right.
care?
And I was gonna you're exactly right, because and let's if we frame this as an innovation, right? Okay, well, this is a new discovery. So often the problem with innovation isn't whether or not it works, it's whether or not it can be implemented.
Right.
Right, and whether
Right.
it can be adopted. So and you were absolutely right, you could see it in my eyes, right? I was gonna say, what's been the barrier to adoption?
Yeah. And there are a couple answers to that question. The number one was the education issue. Again, probably 85% of my oncology colleagues simply don't know the hardcore science.
Mhm.
And come on, among our colleagues, unless you've got overwhelming evidence for a lot of things, there tends to be a natural resistance to accepting it, right? So, number one is education for our colleagues, our medical colleagues. Number two is the general public doesn't know about it. I'm
Mhm.
involved with a group out of Dayton, Ohio called Maple Tree Cancer Alliance. Maple Tree provides certified exercise oncology trainers and specialists to about 90 hospitals in the United States, has also a location in Brazil and export educational programs internationally. It's really interesting. They've got a prospective database over the last 15 years with a little over 20,000 patients. What percentage of patients newly diagnosed with cancer do you think were exercising even at all regularly prior to their diagnosis?
Oh, I would imagine if you took a general population, it would be 10% or less.
Yeah, it's actually right around 14%. The supposed national number is 21 or 22%. I find that hard to believe, but you're absolutely right. Dr. Karen Wonders, who runs Maple Tree, has shared with me anecdotally that patients were more worried about starting an exercise program than they were doing chemotherapy.
Wow.
But think of the amount of sedentary lifestyle. You know this as a cardiologist. The amount of obesity. We're approaching 50% of our population are obese. They're sedentary. They're not, and they're frankly, they're scared. But it's like you said earlier, the coaches can get them going, do best baseline assessments, then create an individualized prescription for that patient based on what their baseline is and also obviously what cancer is being treated, where they are in their treatment, etc.
Well, and there's certainly a corollary here to cardiovascular care in that we have had for many years as part of a standard approach, certainly after my heart attacks, myocardial infarctions, surgery, is cardiac rehab.
Yep.
And, the thing about cardiac rehab, we offer it all the time. And I tell people, listen, it makes you live longer, right? But back to the adoption question, it's hard to get people to really sell out for it. And that the people who do love it. But I would say, and I don't have the number off the top of my head, but unfortunately, too small a percentage of people are able to go through cardiac rehab. It's a little bit time intensive. There's usually some cost associated. It's not fully covered. And so I think, I can envision as you describe this a very similar paradigm, but I wonder if it would probably take a little while because it's definitely not part of the way I would think the traditional oncologist is going to think about prescribing this and just even setting up the infrastructure to make it work.
Yeah. So the other barrier, before we get to infrastructure, the other barrier, of course, is reimbursement.
Right.
And by the way, the model for all of this is exactly your model. It's cardiac rehab.
Yeah.
We've been telling people for 10 years or more. I know this, if we had this much data on a new surgical procedure, we would have been standard of care 10 years ago.
Absolutely.
So the reimbursement is the other big barrier. And Karen Wonders, folks from our cancer society, even folks from ASCO and others have been dealing with CMS for the last few years. A proposal was put in a year and a half or more, almost 2 years ago, for a national coverage determination.
Mm-hmm.
And that's the normal process. CMS was very interested in it, went through 2 drafts of it, and they said, hey, we'll give you the final determination late after the inauguration. So you know what happened next.
Okay.
Everything blew up at that
Right.
point, okay? CMS blew up, everything blew up. So we're still on hold trying to get the reimbursement that we need.
Yeah, but like you
But
say, it could
unbelievable.
probably fold right into a similar infrastructure that already exists. I mean, you could just multi-purpose cardiac rehab for a similar.
And as a matter of fact, at some of the programs that exist, there's a little over 2,000 programs in the United States that vary in size and shape, and in some they're doing exactly that. They're blended into the cardiac rehab program. Most of physical therapists are, frankly, other than lymphedema specialists, they're pretty much involved with orthopedic kinds of issues.
Right.
They're not really. There are very few physical therapists who have the codes, the deconditioning codes, the sarcopenia codes, and the others. Very few of them that are actually in cancer rehab, if you will.
Right.
And the folks that we put out can work in departments of physical therapy along with the supervising physical therapist. Once once we get reimbursement, and we will, there will be an infrastructure issue of having enough specialists to run these, but people are already starting to plan ahead for that. Programs are growing as far as training these kinds of individuals, et cetera, et cetera.
That's great. And I wanted to ask you, have you seen that the beneficial effects are fairly consistent over different cancer types, or is there some more than others?
Outstanding question. The most of the data from these 3,000 clinical trials are on breast cancer patients. And the benefits there are almost identical to what I shared with you on the challenge clinical trial. Improved survival in the 31 to up to 36%, lower recurrence rates in the high 20s percent. And the biggest bang for the buck regardless of the cancer, is actually the lowering of all-cause mortality. And that number generally runs between 35 to 40% or slightly higher. So, and I mean, frankly, the biggest killer, or one of the biggest killers of cancer patients is actually your world. It's
Heart disease.
cardiovascular disease.
Sure. Sure. And you can imagine, or at least I would imagine, that after a cancer diagnosis and going through that treatment, even if you were fairly active at the beginning, there's a risk of you becoming less so just by maintaining.
You're absolutely right. I'm a University of Michigan guy. I did med school there, surgery training, and stayed on the faculty of Michigan for about 14 years. There was a Michelle Seeger at the University of Michigan whose whole world is sustainability. In other words, once you start an exercise program or other things, how do you sustain it? Because it's like sort of New Year's resolutions. You do it for a while, then forget it.
Of course.
And so that's, again, we're getting family members involved, getting involved with groups. And the other thing I need to emphasize here, this is a continuum of care. Starting, as I said earlier, at prehab, right at the time of diagnosis, through active treatment, but particularly out into long-term survivorship. Or, to put it another way, out into the fitness industry. And there's more and more interest building in the fitness industry to become involved in helping patients with chronic disease, whether it's diabetes, obesity, cancer, etc. One of the real leaders in this is the Live Strong Foundation out of
Okay.
Austin.
From Lance Armstrong, right?
Yeah, from Lance Armstrong. Even though he crashed and burned,
Right. His vision was on.
his downfall was rather spectacular. Thank goodness the foundation still exists, and they're in YMCA's across the country.
Wow, that's
And
a
in
great
fact,
community organization.
the
Yeah.
folks at Maple Tree are now recertifying all of their trainers. The program is called Cancer Fit, and they work with personal trainers and other yoga instructors, Pilates instructors, and others to get them really prepared to work with all types of cancer patients in long-term survivorship.
So when I introduce exercise to people, especially around the first time I'm seeing them or after a cardiovascular event, and I talk about exercise, I generally make the case, and this has been well supported, that the benefit of exercise really comes, the most benefit really comes from those who do almost nothing to just doing a little bit. So, I'll often try to say, it starts by doing something. So, in a similar vein, I would give you the chance if someone's listening to this, they or their family member just had a cancer diagnosis. This isn't been part of their life. They're probably not going to get real great recommendations in this regard because it's not universal yet. What are the first steps that they should take right now?
Literally the first steps. I kid you not, literally move. Some movement is better than no movement, period. Whether that's walking around the house, walking around the block, whatever it may be, riding your bicycle, swimming, a racquetball, playing pickleball. There was big interest potentially in getting pickleball associations involved with cancer survivors. Just start moving and build the habit. Most people just don't have the habit built in. And then obviously getting somebody who can partner with them to really urge them on is what's really important. But the bottom line here is some movement, as you said, is better than no movement. Okay. And start slowly and build from that. And that's what the instructors do. They establish what a baseline is for a patient and then gradually and slowly increase the amount of what they're doing, the length of what they're doing, and let's say in weights, slowly increasing the weights, whatever it may be. It's a progressive process. It's one of my favorite expressions is it's evolutionary, not revolutionary.
Well, listen, Jay, 1 in 3 Americans, I believe, will get a cancer diagnosis in their lifetime. So everyone listening and hearing this podcast episode today is going to be in some way, whether themselves or a family, almost certainly touched by cancer. This is fascinating what you're doing. How can people learn more about the work that you're involved?
Yeah, we'll start off and simply Google exercise oncology, number one. It'll take you to all sorts of different places of information. Second of all, if I can put in a plug for my website, please
Please.
come visit us. It's called Cancer Fitness. It's a .org, cancerfitness.org. We have a lot of detailed information about what exercise oncology is. We have instructions about how to get started. And we also have videos and written blogs. And if people would like, and Will, I'd love to add to you. I have an email list now of approaching 550 people in 28 countries. Please make sure I've got your email. If you would like, I'd love to add you to my email list. And on my email list, providers, educators, or cancer survivors and others, there's a link at cancerfitness.org where you can subscribe. And I would love to add people to my email list, okay?
Absolutely. I will certainly give you that. And I can tell you, Jay, not only did I learn something today, whenever we do these CME courses and whatnot, they always will ask you things about did this change your practice? I can tell you that this conversation will change my practice because although I don't treat cancer directly, I certainly am involved with the care of a lot of cancer patients. And I now feel very confident in recommending exercise, not just for heart, but for their cancer treatment as well. And I'm definitely going to pull the challenge trial, but I'm going to take your word for it on those great results. And I want to thank you again for this wonderful conversation today. I truly enjoyed it.
It was truly my privilege, Will. Thank you for the opportunity.
Absolutely. And thank you, everyone, for listening to what was, I hope, a very important episode for you as well. I hope you learned a lot today. And I hope that I'll see you back on our next episode of the Healthcare Algorithm. Until then, be well.